Yes, sir. We are starting the webinar. So, good evening, all. I am Dr. Rambir Gulelia. I am Assistant Professor at the Department of Physical Medicine and Rehabilitation, AIMS Bilaspur. So, on behalf of Academy of Pain Physiatrists, I welcome you all for today's webinar. And the today's August speaker is a very eminent teacher and great personality. And everyone is well versed with his name in the field of pain medicine. Gautam Das, sir. Welcome you, sir. And I share a story, some my memories with sir. I got opportunity to listen to sir during my DNB residency 11, 12 year back in the first ICRA pain conference in the Novotel. So from that time, I am following the sir and try to follow the path of the pain medicine. So welcome again, sir. And now today's session will be moderated by our Honorable President, sir, Dr. S.L. Yadav, sir. He is a renowned teacher in the field of PMR with more than 35 years of experience. Welcome you, sir. And today's
Thank you very
webinar
much.
is uh, sponsored by Avenos. And Avenos is a global medical technology company offering advanced pain management solutions, including cooled radiofrequency ablation for chronic pain. So now I hand over this session to the Yadav sir. Sir, please introduce our today's speaker, Das sir.
Hi, good evening, everyone. Thank you, Rambir, for your kind introduction. So today, the speaker is Dr. Gautam Das, who is internationally known figure in the pain management. And he had completed his fellowship program in conventional pain practice from the World Institute of the Pain from USA in year 2007 and serves as an official of FIPP examiner as well. So, and he has got, leadership like the post-chairman of World Institute of Pain, regional sections of editor-in-chief and editor of prominent pain journals across the globe. He's a great innovator. So he's on his account, he's authored 2 textbooks and 2 handbooks on pain. He's also pioneer of international joint clinical training courses since 2013. He is recipient of the Global Excellence in the Pain Practice awarded by World Institute of Pain in 2010 and world first sweep across clinical research and training categories. So he's a great guy, and today we are lucky that he's with us for this evening. So I think probably now he can enlighten everyone. And today he's going to talk on the principles of radiofrequency ablation, indication-wise Indian guidelines, and the clinical evidence comparing standard versus the conventional RFA versus cooled RFA in osteoarthritis knee. So something is a great, like that everybody is using the cooled RFA nowadays. And so he's going to comparison also between the conventional versus the cooled RFA, so that at least we could be more learned that what gadget we need to use these days to while we treat the osteoarthritis knee. And I request all the audience that they should submit their queries through the Zoom chat or use the raise hand features so that we can take up their questions when Sir ends with his talk. So now everything's with Dr. Das. So over to Dr. Gautam Das. It is yours, sir, now.
Thank you, Dr. Yadav, and thank you, the organizers, for inviting me. I'm really honored. And I'll be, apart from this lecture, what I'm going to deliver, I'll be taking this opportunity to invite you all to join ICRAPEN. I will be, at the end of my slide, I want to talk a little bit about the ICRAPEN. I don't know everybody of your society. I'll be inviting senior people to join as faculty, and those who are younger, they can join as delegate. In fact,
Yes,
I'll
sir,
be
we are aware
asking.
about ICRAPEN, no, like
I'll
so
be I'll
we are
be
planning to
asking
join this.
Rajiv to give me the senior physiatrist name who are interested to join as faculty. I'll be very happy. And
Sure, sir.
let me give me the opportunity at the end of my slide. I'll be talking a little bit about the ICRAPEN. This year it's 10th ICRAPEN, so it is going to be in a very large scale we are organizing. Okay, so let me share. Am I already the co-host? Can I
Yes,
share
sir.
now?
Yes, sir.
Yeah,
You can
please.
slide your share. You can slide.
Okay. Okay, so what I'll be discussing, the basic principles of the radio frequency and what are the different types of radio frequency. You should not be having any confusion. What is pulse radio frequency, what is cooled radio frequency, what is conventional, and many other aspects, how to increase the lesion size. So I'll be trying to discuss this, the different concepts. And at the end, I'll be sharing our studies also. Okay, so we very proud to say that radiofrequency ablation in chronic pain in India, our guideline was the only guideline which is based on the evidence and consensus, where all the different kinds of radiofrequency has been included. Means gastric and ganglion radiofrequency, facet joint radiofrequency, sacroiliac joint, knee joint, large. So all those have been included in this guideline. Some guidelines are there, some Japanese guideline, nice guidelines are there, where mostly they have included the knee and few others. But this is the unique guideline and the world's first guideline, we are very proud to say. So what I'll be doing, you can scan this QR code and there is a simplified web page is there. And also you can download it is around 82 pages guideline. So you can download the 82 pages guideline from that site and very simplified for the practitioners. The one pages we have created. So you can scan and you can go through this page as well as you can download the guideline. What I always in my RF lectures, I always tell that as an Indian, we are proud that we could make it. And all the practitioners should be utilizing this guideline. Okay, now let me come to the topic, main topic. So neurolysis is what? We are ablating the nerve. Why we ablate the nerve? Most common reason of ablating the nerve is the pain relief. But particularly the physiatrist, you people are doing another very important reasons neurolysis is your spasticity release. So to relieve the spasticity, sometimes we also ablate the motor nerves so that there will be lower motor neuron lesion and the spasticity might be taken care. But nowadays, because of the botulinum toxin and other things, the ablation of the motor nerves is nowadays done less. But when in early part of my career, I was referred this patient by his physiatrist, particularly in the spastic cerebral palsy, to do the obturator nerve ablation, then the tibial nerve ablation to relieve the spasticity. So these are some other areas where the neurolysis can be done. And neurolysis can be done by the different ways. One of them is your surgery. Surgically, you can cut it. But again, this is not a popular option. Why not? I'll be coming to this point later on. Chemical is another option, though chemicals has a lot of side effects also, because chemical, when you are injecting alcohol or other chemicals, what is the problem? That in which direction it will go, you don't have any control over that. That means inadvertently, the chemicals might be spreading to the other areas and can land up with some side effects and complications. Thermal ablation is the radiofrequency ablation, what we are going to discuss today. And it is the most commonly used the neurolysis technique, both in the benign chronic pain as well as the cancer pain. So this is one of the most commonly done, all over the world, most commonly done things. Other option of doing the neurolysis is a cryoneurolysis, where we are applying the temperature of something around -80 degrees to ablate the nerve. But again, cryoneurolysis has some advantages, but a lot of disadvantages are also there in the cryoneurolysis. And another is mechanically we can inflate a balloon and we can compress the nerve against the bony wall. Like in the gastric and ganglion, we could do the balloon compression and we can ablate the nerve. So there are the different ways to do the radiofrequency. Out of them, most popular and most commonly done all over the world is your thermal ablation with radiofrequency. So we'll be discussing this point, this topic today. So neurolysis has the advantage, like long-term pain relief, side effects of the medicines are not there, and in the long run, it might be cost-effective. But very important part is here, the failure immediately costlier, forget about that. The last point is the most dangerous one. What is it? Deafferentation pain. So I'll be discussing a little bit more about the deafferentation pain so that you will be able to understand the principles of the radiofrequency. Deafferentation pain is when a nerve is damaged, that area supplied by that particular nerve will be hot, numb, If it is a motor nerve, there will be motor loss also. And many of the situations, this area supplied by that particular nerve, the pain might be coming from that numb area. And this is known as deafferentation pain. So sometimes we call it as a dysesthetic pain. So that is the reason why earlier I was telling that the surgical ablation of the nerve is not a popular option. It has been tried many times. It has been tried, but if we are ablating a nerve, there are some noise. Can organizers mute everybody? So deafferentation pain is one of the very important drawback. This reason for the deafferentation pain is crosstalk and ectopic signal. So now I'm coming to the electricity first. To understand the radio frequency, we should have some idea about the electricity. So one important part is your electricity can be direct current or alternating current. What is direct current? So there are two electrodes. One is anode, another is cathode. And the electricity is flowing only in one direction. Classical example is a dry cell. If you're having a battery, dry cell, you will see in one side it is written plus, another side is written minus, and it is always, electrons are flowing always in the same direction. That is direct current. Earlier in our younger days, when we was very small, that time we have seen that DC, this was called DC fan we have seen. So nowadays DC is not there, direct current is not there, household current is all alternating current, AC. So the AC means what? That electricity is changing its direction. So if there is a two electrodes, current is sometimes flowing, electrons are flowing from this side to this side, and again this side to this side. So the change of the direction is alternating current. And in AC, in alternating current, how many times the current is changing its direction, we call it its frequency. So that means we can understand easily the frequency doesn't apply for DC. Direct current, the frequency is not applicable because it is always going into one direction. There is no cycles. But AC or alternating current, they are having the cycles. How many times they are changing its direction. So it is having the frequency. And most of you must be knowing that the household current what you are using have the frequency of what? 50 Hertz current. Means the electrons are changing its direction, flowing 50 times per second. 1 Hertz means what? Number per second. So alternating current has a frequency and household current frequency is your 50 Hertz. Then another very important few points, one of them is voltage. And here we can understand this, but if we are trying to understand it with an analogy of a pipe through which the water is flowing. So if suppose there is a pipe through which the water is flowing, when water will flow? If the pressure on the either side is same, will the water flow? Answer is no. So for the water to run or flow, pressure on one side must be higher and the pressure on the other side must be lower. Then from the higher side, water will flow to the lower pressure side. So same thing happens in the electricity. Electricity, there must be having the potential difference between the two electrodes. Then only current will flow. Then only the current will go. And this potential difference is measured in terms of voltage. So voltage is what? Between the two electrodes, the potential difference. If you are measuring, that is voltage. And we can understand that more is the voltage, more is the flow of current, means electrons will be flowing more. So voltage and this flow of the electrons, or at a unit, at a point, how much electrons are flowing, this is the current, or its unit is your ampere. So ampere is what? How much electrons are flowing at a unit point. And we can understand that the voltage and ampere are directly proportional. Means more is voltage, means more is the pressure in the water pipe, more is the pressure, more will be the flow of the water. Same thing here, that the more is the voltage, means potential difference is higher, the more will be the flow of electrons. That means ampere will be higher. Another point what I have not mentioned here is a resistance. Resistance unit is R and it's ohm. So how much ohm is the resistance? And there it is inversely proportionate with the A. Means if a caliber of the water pipe is very small, even if the pressure is higher, what will happen? Water It's continuously disturbing. Can you all mute everybody? Please remain muted.
Yes, sir. Please continue. I have muted.
So A and R means ampere and resistance, they are inversely proportionate. Means more is the resistance, the less will be the flow of the electrons. So A is directly proportionate with the voltage and A is inversely proportionate with the resistance. Now, most important is your wattage. Wattage is what? Work done by the electricity is wattage. Very simple example, a 100-watt bulb will be giving more light than a 10-watt bulb. So more is the wattage, more is the work done, and W is the unit, and A into V is equal to W. So ultimately, this is what is important. Wattage is important. And in the subsequent slide, we'll be talking this, that the temperature and the wattage and the size of the lesion, they are proportionate. I'll be coming to that point later on. But before that, let us understand what exactly is radio frequency and why it is called radio frequency. Is there any radio inside? Or is there anything which is like radio distally it is working? So these are the very important, the myths. Radio frequency, it have to have a physical contact. It's not that it's called radio frequency because it is working from distally. No, physical contact is must. So what a radio frequency machine does, let me come to this circuit, this directly. So this is the schematic diagram of a radio frequency machine. And when we are attaching in the plug point, what will happen? Its input current is what? 50 hertz, because domestic current is 50 hertz. But radio frequency machine, it converts this 50 hertz current into 300,000 hertz current, or more than 300. Some machines are 400, 500,000 hertz is there. So more than 300,000 hertz. So it is converted from 50 hertz to the 300,000 hertz. So now there will be an active electrode which is put inside the body, and there will be a ground pad in the leg or hand, wherever it is. So what will happen? In our body, there are charged particles are there. Some are positively charged, some are negatively charged, and some are neutral, who don't have any charge. So when the circuit is completed and the frequency of the current is 300,000 hertz, what does it mean? Means charged particles are oscillating, moving at what frequency? 300,000 hertz or even more. So what will happen? If a positively charged and negatively charged ions are close and they are moving in the opposite direction, so what will happen? This friction is going to create heat. So very important to understand that the radio frequency needle or probe, they themselves are not heated. So what is being heated? It is the surrounded tissue, charged particles, which oscillates, which moves at a frequency of 300,000 hertz or more. And that causes the friction with oppositely charged or neutrally charged ions, and that causes it. So heat will not be generated here because current is widely dispersed. So not. And away from the electrodes, gradually, the power will be feeble. It will not be there. So lesion will be restricted closer to these electrodes and not going much away. So now what is very important here to remember, that suppose you have completed the circuit and there is a friction. So temperature is going high. What is the temperature needed for us? Again, this is very important. Just know all those things, but a very quick recapitulation. What are the different degrees of the nerve damage? If you can recall, first degree, second degree, third degree, fourth degree, fifth degree. First degree is also known as the conduction block or neuropraxia. So here there is no structural damage of the nerve, and it can up to 7 days the conduction block might be there. One of the very simple application is when you are applying the cold less than 10 degree, then there might be conduction block, pain relief might be there. Then is second degree. Second degree is also known as axonotmosis. So if you are remembering the structure of a nerve, then each individual axons and dendrites is having a cell membrane, and that cell membrane is known as endoneurium. So endoneurium is the innermost layer of the axons and dendrites, and then several nerve filaments together is covered by another fibrous connective tissue forming a nerve, and that is known as perineurium. And together, different bundles of nerves together is covered by one connective tissue. That is the outermost coverage, and that is known as epineurium. So endo, peri, epi. So if these are damaged, then you call it as a neurotmosis. But if you are talking about the 3rd degree, 4th degree, 5th degree, 3rd degree means endoneurium is damaged, peri-epi are not damaged, so there will be regeneration. If the only endoneurium is damaged, there will be always regeneration of the nerve. And this regeneration is normally the perfect, except in some conditions, there is a risk of deafferentation pain. So around 5% or little less than 5%, the area will be numb, and that area might be having the deafferentation pain. If it is a 4th degree lesion, when the endo and peri both are damaged, then the chance of the recovery is less. Still recovery will be there. And what will happen? There is very high chance of deafferentation pain. And if it is completely dissected, 5th degree, then there will be very high chance of the deafferentation pain, and nerve will never ever regenerate. So this is very basic principles. Now coming to which are going to cause which degree of nerve damage. So when we are doing the cryoneurolysis at minus 80 degree, actually the range is minus 20 to minus 100 degree, then we get the 2nd degree nerve damage or axonotmosis. What is the advantage of this? Advantage is that because all the cell membranes, the axon, dendrites, endoneurium, perineurium, epineurium, everything is intact. So there will be full regeneration without any deafferentation pain. Nerve will be fully, recovered without any sequelae. If there is 3rd degree, endoneurium is damaged, then there is a chance of deafferentation pain. Why? If you can remember what I was talking, that endoneurium is the area through which the sodium channels is manufactured in a nerve cell body, not in the axons and dendrites. And those sodium channels are basically transferred through the endoneurium to the periphery. So if there is a damage of the endoneurium, that sodium channels will be accumulated there, and that can cause the ectopic signals or spontaneous pain can happen. And if there is a regenerations, there might be crosstalk as well. So these two mechanisms, crosstalk and the ectopic signals, can complicate if the endoneurium is damaged. But still it is more if along with the endoneurium there is a perineurium or epineurium is damaged. So that means, coming back to the principle of the radio frequency, what temperature is desirable for us so that there will be no or very few chance of deafferentation pain. So this temperature range is something around 60 degree to 80 degree, maximum 90 degree. If we are going beyond the 90 degree, chance of the deafferentation pain will be there. There will be charring of the tissues and there will be deafferentation pain. It's very high. So ultimately, what do you want? We want the temperature to be there at our fixed level, means something around 60 degree to 80 degree. We don't want more than that temperature. So now, how to control this temperature? Because what we told you, that the particles are oscillating. So if the particles are oscillating, what will happen? There will be frictions, temperature will go high, 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 high. And now there will be charring, there will be boiling of the tissues, right? So there is a feedback mechanism. So these needles, the cannula, RF cannula, they are made up of thermocouple. They can sense the temperature. They themselves are not heated, but they are heated passively. They can sense the temperature and sends the feedback to the machine that, okay, this is your tissue temperature. Say, for example, if we are setting the tissue temperature 60 degree and the electrode will be judging that and sending the signal to the machine that 60 degree temperature was the set temperature and 60 degree temperature has been achieved. Then what will happen? If the machine is delivering the same wattage, what I told you earlier, the size of the lesion and temperature are directly proportionate to the work done by the electricity, means wattage. Means more is the wattage, more is temperature, more is the size of the lesion. But we don't want temperature to go beyond 60 degree, because I have given the instruction to the machine that I want 60 degree temperature. So what machine will do? As soon as the 60 degree temperature is reached, as assessed by this thermocouple, then machine will start lowering the wattage. So if the wattage is going lower, then what will happen? Temperature also will come lower. So from 60, it is becoming 59. And then wattage will be again going high. So again, temperature will be 60, 61. Again, the wattage will be coming down. And again, the temperature will be coming down. So by that way, means by fluctuating the wattage, we are keeping the temperature at a constant level. So what we are compromising here? We are compromising a large size lesion because we are unable to deliver the wattage at a very higher wattage. If we could deliver the current at a higher wattage, we could get a little big large size lesion. But here, because we don't want the temperature to go beyond our set temperature or never be above 90 degree, so we are compromising with the size of the lesion. Some people ask me this question very frequently, that there are radio frequencies available for the tumor ablation. Are these machines are same? Can you use the same machine for the basivertebral nerve ablation or tumor ablation? Answer is no. Why no? Because here, these machines for the pain management, these machines are designed that at that wattage, which will not be creating very high temperature. We want the temperature something around 60 to 80, maximum 90, not more than that. As I told you, if the temperature is going higher than that, there will be more chance of the deafferentation pain. The degree of lesion will be from 3rd degree to be becoming 4th degree lesion. We don't want that. So that is the reason why we are compromising here. So we cannot ablate the tumor, because for the ablation of the tumor, your temperature should go 100 to 110 degree temperature is needed. That means there, the wattage of the machine is much higher, so that you can create a higher size of the lesion and the higher temperature. So that means the same machine what we are using for the pain management are not able to ablate the tumor, because the temperature you cannot go up to that level. And the size of the lesion will also be smaller because wattage is not very high. We need machine which can deliver the current at a higher wattage. Then we'll be able to ablate the tumors. Okay, so coming back, what we are discussing, that the temperature control by a conventional radio frequency depends on what? Depends on controlling the wattage. And if we are controlling the wattage, what we are compromising? We are compromising the size of the lesion as well. Right? So now let me talk about the other kinds of RF, and then again I'll be coming to the cooled RF. What is the principle of the cooled RF? First of all, when we are delivering the current at this high frequency, means 300,000 hertz or more than that, there will be a strong electromagnetic field which is created at around the electrode. What is electrode actually? RF cannula is insulated. Whole of the length of the needle is insulated. Only tip is exposed, and that is the electrode. So if we are the delivering the current at a high frequency, that will create a strong electromagnetic field, and this electromagnetic field have some neuromodulatory effect, and that has been utilized in the pulsed RF. So pulsed RF is what? I'm going to the pulsed RF here. So conventional radio frequency, see, once we are receiving the temperature, the wattage will be going lower, and temperature also going lower. Again, it will be going higher. So it will be going that way, higher, lower, and temperature is kept at a constant level. Pulse radio frequency, what we are doing? We are delivering this high frequency alternating current. High frequency alternating current means 300,000 hertz in a small time, 20 millisecond. And then there will be long silence, no current, absolutely silence. And then again, current for around 20 millisecond. In that way, when we are delivering the current, then this is known as pulsed radio frequency. So because we are giving a long silence, the temperature is not going to be higher. But by this, what we can do? We can have a neuromodulatory effect on the nerve. So patient can be having a good pain relief with pulsed radio frequency. Pulsed radio frequency is a non-thermal radio frequency. So ablation term is not applicable for the pulsed RF. We are not ablating anything in the pulsed RF. We are basically modulating the nerve. Though pulsed radio frequency have a very high failure rate, it is having the best evidence for the dorsal root ganglion, cervical or the lumbar or thoracic dorsal root ganglion pulsed radio frequency have a good success rate. In other areas like Gasserian ganglion and many other, it has been tried with a very high failure rate. So that is the reason why pulse rate frequency is not that popular. So this is one kind of radio frequency, that is pulse radio frequency. So now come to the conventional radio frequency. You see the size of the lesion is what? Shape of the lesion, sorry. It is like a cylinder around the shaft of the needle. Whereas pulse radio frequency, electromagnetic field is created at the tip. So when we are doing a pulse radio frequency, our needle should be perpendicular to the knob. But when you are doing the conventional radio frequency, our needle should be parallel to the knob, so that it will be having a higher contact area, so that the chances of success will be increasing. So this is your pulsed versus conventional. Now I'll be coming to cooled RF. So what I told, cooled RF is what? That there is a circulating channel, water channel through the cannula, this blue line, and through which the water at room temperature is circulated. So what is its function? As I told earlier, we are compromising the size of the lesion. How? Because we are controlling the wattage once the temperature is reached. So water is going down. If people, those who are doing the radio frequency, if you are looking about the monitor of the radio frequency machine, you will see that initially wattage is going very high, around 12 or something like that, 12, even sometimes more than that. But as soon as your set temperature is reached, it will be immediately coming down, and then it will be fluctuating something around 4 or 5 wattage, something like that. So that means initially once the temperature is reached, then it is going higher, but after that it comes low to maintain the temperature. So what we are compromising here? We are unable to deliver the current at a higher wattage, and cooled radio frequency have the different mechanism, additional mechanism to control the temperature. What is that additional mechanism? So there is a circulating channel at the tip at the electrode. So it is taking the heat away. So it is the circulating water is taking the heat away from the tissue. So what is the advantage? That you can deliver current at a higher wattage. And another very important thing to remember, that in the cooled radio frequency, around the needle or electrode, the temperature zone is less, because it is constantly taking the temperature away. And when you are going little away from the tip, the temperature will be higher. Why? Because that temperature is where the temperature control is not by the wattage control only. Here the circulating water, and circulating water is constantly taking the tip temperature away. That is the reason why in cooled radio frequency, very close to your electrode, the temperature is less, and if you are going little away, temperature is higher, which is not there for the conventional radio frequency. Conventional radio frequency, you are coming close to your electrode, the temperature will be higher. I hope you have understood that how the cooled RF is giving a large size lesion. So how it is giving large size lesion? That means because we are having an additional mechanism of cooling or keeping the temperature at a constant level, not dependent on wattage alone to control the tip temperature. So we can apply the current with a higher wattage. And higher wattage means what? Larger size of the lesion. So that is how the cooled radio frequency is creating large size lesion, where around the needle temperature is less, little away temperature is higher, and the lesion will be spherical. What is the advantage of the spherical lesion? It is angle independent. So if it is a nerve, if it is an electrode, so whether you are coming vertically or at this angle or at this angle, any angle it is same, because it is a football, it's a circular lesion, spherical lesion, which is not there in the conventional radio frequency. Conventional radio frequency, your needle and the nerve should be as parallel as possible. So this is cooled RF. Now come the bipolar RF. Bipolar RF is what? There will be no ground pad. So between the two electrode, the current will be flowing. So there will be lesions in both the active electrode, and then that will be creating a larger size lesion. But still, it is having the disadvantage that you have to put the two electrodes there. And second important part is the tip of the lesion needle, there will be no lesion. Like conventional and the bipolar, in both the situation, beyond the tip of the needle, the lesion is not there. But for the cooled RF, beyond the tip of the needle, it will be having a large size lesion, because as it is large, so lesion extends beyond the tip of the lesion. So this is bipolar, but this is also another mechanism to create a large size lesion. And another, this is also very important. Many people ask me this question, that what is the difference between this? Here also you see the two electrodes are there. But here the current is not multi-channel electrode is what? You can use the, the two electrodes, some machines have 4 electrodes. So the 4 electrodes are pressing, but each will be completing the circuit with the ground pad. So suppose this is A, this is B, C, D. So each will be completing the lesion circuit with this, not between them. When it is between them, we call it bipolar. But when the circuit is completed between the electrode and the ground pad, this is monopolar. But if we are putting it multiple, then monopolar, multi-channel, where they'll be having simultaneously 2, 3, 4 lesions you can create. So that is your multi-channel radiofrequency. Now, cannulas size or shape are different. Some are small gauge, some are large gauge. Like it can be 14 gauge. 14 gauge diameter is 1.63 millimeter. And if it is 22 gauge, it is 0.64 millimeter. That means if you're using a large gauge cannula, you can create a larger size lesion by the virtue of the cannula itself. It can be, this length can be 5 centimeter to 15 centimeter. The exposed tip or electrode size can be 2 millimeter to 15 millimeter. More than 15 millimeter, if your the electrode exposed tip is there, then electricity will be dispersed in a wider area and the lesion will be erratic. You may not be having a good lesion size. That is the reason why more than 15 millimeter electrode size is not available. Now, there are different newer cannulas are also there, like venom cannula, where the tip will be protruding another, this trident cannula. Here it is a trifurcation or protruding electrode. So these are the different options to increase the size of the lesion. But study says, even if all the different kinds of newer cannulas are there, till cooled RF creates the larger size lesion. And you can see here that all these things beyond the tip, even if you are using the venom cannula, trident cannula, beyond the tip, there is no lesion size. You see, there is no lesion size. Whereas here is the tip for the cooled RF. Beyond the cannula, there is a big lesion size. That means you can place the needle at any angle, even perpendicular, then also the chance of the success will be higher. So these are the different shapes of the lesions. In the bipolar, it will be dumbbell shaped. This is your, again, the elliptical or spherical, and it will be, elliptical or the cylindrical, and here it will be spherical lesion. Now, second, another very important part is, what is the relation with the size of the lesion with the time? Is there any relation? Answer is, initial 60 seconds, the lesion and time is directly proportionate. More is the time, more is the size of the lesion. After the 60 seconds is reached, then the rise of the size of the lesion becomes slower. After 120 seconds, it is very slow. After 150 seconds, the size of the lesion is almost negligible. So cooled radiofrequency recommendation is you should go up to 150. Whereas for the conventional recommendation is something around 60 seconds to 120 seconds is the recommendation. That means by increasing the size by time, also you can increase the size of the lesion to some extent. The one thing it is not there, that is your, this is again very important. I'm just, the basic concept is what I told you, wattage is equal to what? A into V. So wattage is important. If we can deliver the current at a higher wattage, we can have a higher, the lesion size. So now at the same setup, if the resistance is less, like if you are injecting, saline, or if you are injecting hydroxyethyl starch, HES, you can reduce the resistance or increase the conductivity. So if the resistance is the less, what will happen to the ampere will be more. So then even if the V is same, so this product wattage will be more. So it will be having a large size lesion. So remember, this I have not mentioned here in the list, that by injecting, before doing the lesion, by injecting normal saline or by injecting hexaethyl starch, you can increase the size of the lesion. So what are the ways to increase the size of the lesion? One is, if you are taking the larger gauge needle, if you are increasing the time up to 150 seconds, if you are using the cooled radiofrequency, if you are using the bipolar radiofrequency, if you are using the near cannula, and last one, what I mentioned here, if you are injecting something which will be increasing the ampere, means reducing the resistance. Conductivity will be increased. Resistance is decreased by injecting some conductive media, normal saline. Then also you can increase the size of the lesion. Why increase size of the lesion is important? Because even if your needle is little away from the nerve, the chance of the success will be higher. But of course, increase of the size of the lesion can be sometimes dangerous. Like suppose you are doing the gastrin ganglion block. So very nearby is the brainstem and the other cranial nerves. So if you are having a large size lesion, you might be landing up with some complications. So the increased size of the lesion is not applicable everywhere, but in certain areas where the nerve location is erratic, say for example, sacroiliac joint, say for example, genicular nerve of the knee. So in these areas, the large size lesion is really beneficial. And that is the reason why these are the different options for increasing the size of the lesion. But the best maximum size of the lesion, you are always getting with the cooled RF, cooled radiofrequency. Then before doing the radiofrequency, we have to do the sensory testing and motor testing. Sensory testing means what? Patient will be having some paresthesia. And this paresthesia, for that, you have to deliver the current at a 50 Hz. 50 Hz is the current which stimulates the sensory fibers. And you will be getting the paresthesia at something around 0.5 voltage. Then you know that your needle is very close to around 2 millimeter, 2 to 4 millimeter. Then you should do the motor testing at around 1 to 2 Hz. And your nerve, which is your target, if it has a motor branch, say for example, medial branch when you are doing for the facet joint RF, there should be contraction of the multifidus muscle at a lower voltage. But at the same time, your legs should not be dancing. Your needle should not be close to the exiting nerve root. Then you might be damaging that. So the motor testing is important for both the purpose. To understand that you are not inadvertently nearby to the other nerves, which is not your target, and your target nerve, if it have a motor supply, so you should be able to stimulate those fibers as well. And then your sensory motor decision. What is this? Sensory motor decision means that you should be able to elicit the stimulations, sensory current, say for example 0.5 voltage. And by doubling the current, means 1 voltage, you should not be inadvertently stimulating the other nerves which is not your target. So this is known as sensory motor dissociation. So now these are the different conventional radiofrequency indications. Particularly these are important where the nearby structures are there. We need a small size lesion. Then pulsed RF, as I told you, these are the other areas where it can be done, but mostly it is done for this dorsal root ganglion lesion, because here the ventral root is very nearby. If you are having, if you are touching or nearby the ventral root, patient might be having the paralysis. So that is the reason why pulsed RF is still popular for the DRG. In the other areas, it has been tried with a varied success rate. Cooled RF is coming up with a lot of indications. The most important indication is your large joint, knee, hip, shoulder, sacroiliac joint, facet joint, not just lumbar facet, even cervical facet joint, it is coming up. So wherever we want a large size lesion, wherever there is anatomical variation of the nerves and nearby important structure is not there, cooled RF can be your best choice. Bipolar RF is also where you want a large size lesion. Bipolar RF has some evidence in the sacroiliac joint, ganglion impar. Ganglion impar, what we do? We put one needle between the S5 and COX6-1 and another needle between the COX6-1 and COX6-2, and we can have a large size lesion there in the ganglion impar. In other areas, we can do, but better is your definitely cooled radiofrequency. So this is our study, which we published 2 years back in India Journal of Pain. So here we have compared the conventional radiofrequency with the cooled radiofrequency in ablating the genicular knee ablation. So I'm just sharing with the summary. So summary is that initial result was similar. So now why the initial result with the cooled RFA and the conventional RFA is similar? In the discussion we have mentioned that initial result might be similar, because in both this situation, after doing a thermal radiofrequency, you have to always inject some steroid. Why? Because steroid have some membrane stabilizing effect. As I told you, that the radiofrequency procedure has less chance, but still there is a chance of deafferentation pain. Sometimes it is called as neuritis. Neuritis is a misnomer. Actually, the radiofrequency do not cause any inflammation, but still there is a deafferentation pain, and neuritis is the popular term used, and this can be prevented with the steroid, not because of the anti-inflammatory action, because steroid also have its membrane stabilizing effect. So if we are giving steroid, so our postulation hypothesis was that conventional cooled RF initially gives the similar result because we are giving steroid in both the situations. So steroid will be spreading and it will be blocking even if the needle is little away from the nerve. But long term, after 6 months, the result of the cooled RF is much superior than your conventional radiofrequency. Means the in conventional radiofrequency pain come early, whereas in cooled radiofrequency, patient continues pain relief even beyond 1 year. So this was a good study, and this was published in the Indian Journal of Pain. I'll be sharing, those who are interested to read it, I'll be sharing in the chat box. I'll be this study article, so you can go through it. Okay, and before ending, I was telling we are going to organize the 10th ICRAPEN, and I'll be, as I told earlier, the senior physiatrist can join us with as faculty. I'll be telling the Rajiv to communicate with you, and we'll be very happy to host you and invite as a faculty, and others they can join. There are lots of the things which will be there. Most important part is this time there are more than 20 international faculties are coming from different worlds, and the very renowned faces are from Korea, Malaysia, the US. Lot of prominent faces are coming who are the society's secretary, president. So this kind of people that are coming, who are the authors, who are the innovators. Lots of researchers are there. So you can go through our website icrapen.com in the below. So this website you can go. You will be seeing the profile of these international faculties who are coming. And a lot of important upcoming topics we are discussing, like facial plane interventions and the truncal blocks are very important nowadays, because fascia is very important pain generator nowadays, which is our target. And how to do the facial plane hydrodissection. So that is one of our very important topic for this conference. Second important part is whole of the regeneration therapy, means starting from the PRP, the bone marrow aspirate concentrate, the different kinds of fat preparation, nano-fat, M-fat, SBA. We are having the live workshop, pre-conference live workshop where we'll be demonstrating all those things. So we are having 3 sessions on the regeneration therapy, and there will be one free workshop during the conference where the instruments and the machines will be demonstrated, and video sessions will be there in that workshop on the regeneration therapy. So this is also a very important topic. And apart from that, there are other regular things like radiofrequency, cryo, MSK ultrasound, neuromodulation, spinal cord stimulator, balloon neuroplasty. This is again invented by the Korean doctors. So they have invented some balloon through the caudal epidural route. They are inflating it, and that is one of the very important option to treat the spinal canal stenosis. So they have done several thousands on it. They have already published it. So balloon neuroplasty is one of the very important topics which will be covered here. Apart from that, the AI is another important area. AI means the Korean people are very innovative in the patient cloning, AI patient cloning, XR guided pain intervention. So the other topics are they'll be delivering. So I'll be asking all of you to join pre-conference workshop there on 3rd, post-conference workshop is there on the 6th, and 4th and 5th is the conference. So thank you very much. This is the conference registration link. You can register for the conference, and through Rajiv, I might be getting few names who are interested to join as faculty. So now I'm ready to answer your questions, and also I'll be sharing our this journal publications, that is cooled versus conventional radiofrequency, the need regular now. But apart from that, any other questions regarding the radiofrequency or principles? Very important. We should be understanding what kind of radiofrequency, why the size, where the temperature is being. I have seen in people are delivering the lecture where they're telling that the radiofrequency needle itself is heated. No, radiofrequency needle never heated. It is the surrounded tissues that is heated. Same way, why it is called radiofrequency? Because the alternating current more than 300,000 hertz is the similar that of the radio wave transmission. That is the reason why it is called radiofrequency. That means if you are mechanically moving something, vibration of more than 300,000 hertz, then also it can be called as radiofrequency. Means anything which is at that frequency is called as radiofrequency. So there is nothing related to the radio, and there is nothing related that some people tell that it is from the distance it is creating the lesions. Answer is no. It has to have a physical contact. Then only the radiofrequency lesioning is possible. So similarly, if you are having any more questions, you can ask me.
Yeah. On behalf of Academy of Pain Physiatry, I would like to thank you, Dr. Gautam, for a very, very excellent talk. Like you just shared the all in-depth knowledge that how the ablation therapy works. I think basics to the advanced, where you had talked about differentiation of pain if temperature goes beyond 90 degree, and like how the cool ablation therapy works, like that it takes away the heat away, and similarly, targeting the bigger lesion. And you had also talked about like that what are the therapies, ablation therapy, like conventional to bipolar, the cooled and the multi-channel, and how really it's basically different from each other. And good that you discussed about time versus the lesion size, because everything is have own importance. And like that, how the cannula influence the outcome in the pain reductions. So really, it's a very good talk. And I'm pretty sure that because the audience number was pretty full, like that we kept around 100 slot, and it was attended by 100 audience. So that was really excellent show. And the way narrated everything, make things so simplified. It is really, I also learned a lot about these cool ablation therapy and versus the conventional therapy. What are the differentiating point, and how really does it help to that reduce the pain in different kind of the entities. So really, I'm pretty sure that everybody might have been like they got benefited out of it, who they are in to have the the pain management. So in the chat box, there's few questions. Like one question from Dr. Saida Shakila, like which is better, like cool ablation versus just wait.
Sir, cryoablation versus RFA for knee OA. Which one is better?
Oh, okay. Yes, Dr. Gautam.
Just a minute. I'm just sharing this study. I have shared in the chat box. So those who are interested can download it. Okay. Can you repeat the question? I missed it.
Sir, question is which is better, like cryoablation or RFA for knee OA? Which one is better?
We are conducting one study where we are basically the cryo versus cooled radiofrequency we are comparing. What are the initial findings is the cryo, the most important limitation is duration of pain relief is much short in the cryo. That is one of the biggest disadvantage of the cryo. That means the size of the lesions, initial results are almost similar, but the duration of the pain relief is longer with the cooled radiofrequency than conventional radiofrequency. So in that way, we can tell that okay, for the knee genicular nerve ablation, the best radiofrequency type is the cooled radiofrequency.
The other question, can we repeat the RFA? If yes, how much gap we can give in between the treatment?
So repeating is not an issue. You can repeat it. But at the same time, we have to remember that if we are repeating it too often, then there is a possibility of the deapprentiation pain will be more. So this is one of the very important limiting factor. But there are studies which is telling few times, no specific time mentioned, means when the pain will be coming back, we can repeat the procedure. But more than 3-4 times, same procedure, same nerve ablation might be landing up with the deapprentiation pain, dysesthetic pain. So you have to always keep that in mind.
So like, is there any frequency that how many ablation can be done? Because not to have any negative effect.
There are no clear-cut studies. There is no clear-cut studies that this much of ablation should be done. But whatever the literature is telling, that the repeated means several times. How many times? Again, that has not been mentioned. That the
Oh.
several times repetition of the ablation of the same nerves again and again, that can lead to the dysesthetic pain. That is the drawback. But otherwise, if the question is asked, can you repeat? Answer is yes. When can you repeat? When pain returns back. When pain can come back, we can repeat.
वही लग रहा है नर्सिंग वाला ना अगेन उसने जो के कंपेयर हुई है जहाँ तक वही हाँ मस्त है
Any more questions?
Chat box is if RF ablation machine same as RF coagulation machine for bleeding?
No. I told you at the beginning that it's not the same. In the RF, the coagulation for the bleeding, what is basically the RF diathermy, RF, what is used in the tumor ablation, they all are meant for the different designs. Here, our aim of the temperature is something around 60 to 80. So these machines are designed for that. Wattage depends on that. So that is the reason why the RF, the coagulator, what is used in the surgery for controlling the bleeding and the tumor ablation, and in the WPW syndrome in the heart, it is also ablations. So they are not the same. The machine cannot be used for the similar, for the interchangeably cannot use it. So the machines are designed in that way.
One more question from chat box from Dr. Prashant. How long does RFA takes time to pain relief?
This is again very important question. We should be always telling our patient that the effect is not immediate. Immediate effect is because of the local anesthetic and sometimes local anesthetic steroid, but then the pain will come back. And the actual onset of action of the radiofrequency is something around 2 weeks to 4 weeks. So in some literature, sometimes it can pain relief can be even after 6 weeks, but it is never immediate. Most commonly, this window period will be there, and the pain relief will be starting something around 2 to 4 weeks.
Okay. So best way to manage the differentiation pain once it is started?
Differentiation pain management is very difficult and there is no interventions to manage it. So we have to rely on the pharmacotherapy. Means differentiation pain, what is the feature? Patient will be having the spontaneous pain, patient will be having the burning sensations, and patient will be having more or less continuous pain. So here again, like managing any other kind of neuropathic pain, the main the medicines are your anticonvulsants like gabapentin, pregabalin, carbamazepine, and antidepressant like the amitriptyline, nortriptyline, duloxetine. So combination of these kind of drugs should be used, and the treatment option again, how long the patient will suffer and whether the patient will be recovered. It is all the luck. Some patients recovers with the medications, some patients are well controlled with the medications, but some patients the problem continues. And if somebody is asking that what are the treatment option for these conditions if the pharmacotherapy has failed. So in very bad conditions, like suppose somebody is having a failed back surgery, some nerve is there, some permanent damage of the nerve is there, and the patient is not responding to the neuropathic medications, how we are going to treat it? We are treating these patients with the spinal cord stimulation implantation. So same way here, the dysesthetic pain, if it is not responding to the pharmacotherapy, no simple nerve block or no simple technique is available to take care of this pain. So only option apart from the pharmacotherapy is the spinal cord stimulator to take care of this neuropathic pain.
So if some patient is on antiplatelets, do we require to stop before we plan for the RFA?
Antiplatelet depends on what kind of antiplatelet patient is getting. Up to 75 milligram aspirin, we need not stop it.
Okay.
But if it is more than 75, means if some patients are getting it, taking it 150 milligram, or if the patient is taking clopidogrel or similar kind of anticoagulant, then it has to be stopped for 7 days before doing the procedure. But if it is 75 milligram aspirin, then it is
not
allowed.
required to stop. Yeah?
No need to stop it.
Okay, right.
In fact, suppose somebody is on the clopidogrel and we want to do some procedure there. So what we recommend them, stop clopidogrel, start aspirin. Don't stop everything together. Start aspirin. After the procedure, again, you come back to your clopidogrel.
Or else we can ask for the PT-INR and then on basis of which
that is also another options. But in general, particularly for the spine procedure, the anticoagulant more than 75 milligram aspirin should be stopped.
All right. So what the role of the cannula size which influence the outcome in the pain management? Does it have any role?
Yes. As I mentioned, one of the important way to increase the size of the lesion is taking a larger gauge cannula. Means I have mentioned there in the chart that the 22 gauge cannula, the size is 0.63 millimeter, whereas the 14 gauge cannula is 1.63 millimeter. Means 1 millimeter increase size of the lesion is possible with taking the larger gauge cannula. But again, what we are compromising? We are compromising with the thicker is the cannula, more invasive, more pain to the patient. So you have to judge and assess with that. If you are taking a very small, then chances of failure is more. And if you are taking a very large, then it will be more painful to the patient. So we have to choose a middle path. So something around 17, 18 or 20 gauge cannula most commonly we are using. But again, it depends on what procedure you are doing. If you are doing a gastric ganglion, definitely 22 gauge cannula will be preferable, because there we don't want a large size lesion. But suppose you are doing a genicular nerve ablation, definitely a larger cannula will be increasing your success rate.
So now I'm not able to see any for more questions.
One more question. Yadav sir, one more question.
Yeah.
Yes, sir. One more question by Sai Chandan. He's asking, we are performing CRFA, either he's talking about cooled or conventional RFA for knee-OA. How to control the pain during the CRFA procedure? Many patients complain about the unbearable pain during the 2 minute 30 second ablation procedure.
That is true, and many people do many things. Some people gives the spinal anesthesia, some give general anesthesia, so like that. What I do when I do the radiofrequency of the genicular nerve, it's very painful, because if we are touching the periosteum, because we are touching the periosteum is important. We are very close to the periosteum when we are doing it. And most of the times what I do not stimulate. Though ideally the stimulation should be done, and to get a stimulation, you cannot give the local anesthetic in the deeper structure. You have to give local anesthetic only to the superficial structure. So your success will be increasing if you are getting the stimulation. But another way to get the success is if you can visualize under the ultrasound guidance if you are doing, and if you can visualize the genicular artery, then also success rate will be increasing. So what I do, and that makes the procedure very easy, very simple, that I give liberal local anesthesia around the genicular artery. Just skin needle, I'm not just giving the skin. I go up to the deeper, and I don't do the sensory motor stimulation. So why I'm not doing sensory motor stimulation? Because I am relying on the arterial pulsations to increase my success. So that makes the procedure easy. But again, some people, as I told you, some people do it under the spinal anesthesia, some people do it under general anesthesia. So all those things people are doing. And this is true. Unless you are giving liberal local anesthetic, it is really painful.
Thank you, sir. Thank you. Over to Yadav, sir.
Yeah. It seems to be like that everybody is fan of Dr. Das. So still, like tomorrow, maybe the resident would like to go for work. They're still, sitting at the screen. There's something loud speaks about Dr. Das. And I really
thank you so much for your nice words.
APP once again, and also thanks the audience that they are with us at this late evening even. And before we close the session, I would like to thank Avanos for enabling this platform for the knowledge sharing and for their ongoing efforts to support clinician education and improve patient outcome. We also extend our sincere gratitude on behalf of APP to Avanos Medical for their valuable collaboration and support in organizing this educational webinar. Through continuous innovation and the commitment to advancing patient care, Avanos has been trusted partner in promoting evidence-based pain management practice. So thanks once again to our, this support partner, Avanos, to Dr. Gautam Das, and at the same time to the audience. Have a great evening, and thank you very much to everyone. Over to Dr. Rambir.
Thank you, sir. Thank you, Das sir, for joining us. It is very enlightening talk, and we have learned a lot. Thank you so much, sir.
But very useful talk, like because
Yes.
basics we don't know. Like we can treat the things, but we don't know those basics which sir has told us today. Like there's something great.
Definitely.
Yeah. Thank you,
So
sir.
good night, sir.
Thank
Have
you.
a
Thank you for
great
this
evening, and
opportunity. I am also very
see
much
there at
honored to
Extra
deliver
Pain.
lectures in front of the learned people. So I am also very much honored. And
Thank
again,
you.
before going, again, I'll be inviting for the ICRAPIN, 10th ICRAPIN. I'll be
Yeah,
inviting
sure,
all
sir,
of you
sure.
to join there.
And everybody thanking in the chat box to like that shows that how great you are. Thank you so very much, sir. Have a
Thank you. Thank you.
good evening
Thank you.
again. Okay.
Thank you.
Rather good night by now. Thank you very much. Thank you, Rambir. Thank you
Yes,
for
sir.
support.
Welcome, sir.
Thank you for supporting me. Thank you very much.